regular clinic. Well, but we might get, a case manager might call us, and I think we talked about case managers and adjusters in Doug's presentation. Case manager generally has fewer patients underneath them, and the adjuster usually has few case managers underneath them. So case manager might call and say, I've got this patient, or the doctor's office might call, and a lot of the orthopedic practices that see work comp will have a dedicated person for work comp. So you'll know, like at DFP, at Driscoll and Parkins, it's Jane. So if we're going to call, we're going to talk to Jane. Or Jane will call us and say, hey, Dr. Krempak has this hip patient he wants you to see, or the other. And so we'll get that initial order, and then we will have to get a hold of the case manager or the adjuster to make sure that everything is approved. Can't just schedule them. The patient can't just come in and schedule their visits. So and our front desk does a great job. They'll take care of all that and letting us know how many visits they have. The doctor's office calls, we still, again, have to get a hold of the case manager. And this is when you're in a first ask, that first contact with the case manager, that you're going to ask for a job description. Because she's going to need it for Strive to develop their program. She's going to need it for an FCE if they end up having to do it. We document, and I'll show you later in our evaluation where we document how many times we contact the case managers. And they really want us at least once a week contacting the case manager or with the doctor's office. Tends to be more the case managers. So, and in the initial evaluation, it's going to be set up just like your regular orthopedic patient, with the addition of, should I go to notes now, you think? Sure. Escape. Takes me a little while. I'm very technologically challenged. Okay, so this is what our initial evaluation looks like. So patient details, this was the tab I'm under. Our admin will have already put in their medical diagnosis. And this, okay, you can see this patient's name because in work comp, as soon as you sign in that it's a work comp injury, you are basically signing away your HIPAA rights. Meaning that we can collect this metrics, we can collect data to measure outcomes. And because we have to be able to contact their doctor, their case manager, their adjuster. So that's why you can see this is not blacked out. So if Sam didn't want to go by Sam, we'd put his name, different name in here. If we didn't like that it was a lumbar strain, we could put in a medical diagnosis override. It's actually a patient I saw today, so which location they're going to be seeing him. You can tell here the injury date's not in here, but it's up here. So if we had to put in a surgery date, we could put that in. And we just have to hit down here, data incorrect. So even before we get to subjective, we got a couple other tabs we have to cover. Risk assessment. So we'll put height and weight. It'll automatically calculate the BMI. So before I even do anything, it's already put a little check in here that Mr. Sam is a little overweight. And we'll go, is this oh no. Is it a surgery? No. If we look at date of injury, and we'll cover this in metrics in a little bit, but the average time from injury to entering an ARC clinic is 177 days. What do you think happens in that 177 days? How often do you lose, how quickly do you lose muscle strain? Was it 4% a week or a day if you're hospitalized or bedridden? So that's something to think about. We'll ask, have you had a previous related surgery? This is a lumbar strain. He did not have a previous surgery. We'll ask if they have an assistive device or anything that they're using. You're going to know that if they come in with crutches or a back brace on. But Sam actually had, and I should probably check this because he did come in with a knee brace on, but that really wasn't the primary thing we were seeing him for. Failed therapy. This is important because if they've already been in the system, and you can tell because his date was just last week, that he hasn't gone to a corporate care, a U.S. HealthWorks, Emeritus, where they're good PTs there, but a lot of times they do a lot of palliative modalities. So they're not really learning anything about their condition. They're just, this is going to feel, we're going to do ice, we're going to do stim, we're going to do ultrasound, we're going to do heat. So you'd like to know if they've had active therapy or not. Current smoker, that's important, affects their outcomes. Did they lose their job, or are they unemployed? Did they suddenly get fired and file a complaint, or file an injury? That's important to know. English is a second language. If we'll ask that, if we usually know if they're Spanish speaking, and they have to, because they'll come with an interpreter, or the case manager will know, and they'll schedule an interpreter. Have they had a previous history of work comp injury? And they might want to tell you here, oh yeah, I did, blah, blah, blah. You know, hold on for just a second, I'll cover that when I get to my subjective portion, but I'm kind of just gathering risk assessment, because this is where we take our outcomes measures from. Other comorbidities we look at: diabetes, osteoarthritis, rheumatoid arthritis, hypertension, autoimmune disorders, cardiac issues, and cancer. So Mr. Sam did fine with all of that. We'll also ask, like, well, I know you have a case manager, I know you didn't have surgery, so do you have an attorney? Well, why do you want to know? I said, well, we track it for outcomes research, because and you'll see, it increases on average per case 2 to 3 visits additional if they have an attorney for the same diagnosis. No comorbidities, I rarely check that. You ever check that? Okay, so now I'm going to escape and go back to, I think I'm going to escape. What? How come it didn't escape? All right, I'm just going to go to,
So do you want to do outcomes?
yeah, we're going to go to outcomes. Whoops, from the beginning. Okay, so this is in 2015. That's actually Anna on her lovely trip to Italy. Not my computer wouldn't work. So we saw 3,213 patients in 2015. Our average age was 45. And our average PT/OT visits, 11.1. Average days in PT, about 38. And here's that average time between start of care, injury and start of care. What do you think our top 3 body parts are? There you go. Shoulders, back, knee. 16, average visits by body part, 16 visits per shoulder, 8 for lumbar. I wish I could hang my hat on, we are all McKinsey trained, and each clinic has at least one McKinsey certified therapist. I went through that training, and it's taught me a lot about how different ways to treat backs. It's very self-management focused. So I think that is one of the reasons that number is quite low. So here comes what drives the cost of a case up. If you of our cases, roughly 1,000 had surgery. The time from injury to start of care will drive it up, and then the comorbidities. How healthy is your workforce? We're not really still doing. We were doing healthy workforce, where we would actually go out and we had a program that would set up exercises. If you could, we would come in and we would evaluate your workforce. We would, we could put them on weight loss programs and exercise programs. So we could, because we could go into them and say, do you know that if you are, I'll bring it up when we get to the obesity parts, but that's probably don't really. Sorry, somebody else prepared this. We talked about the average. Here is of those 3,200 patients, 48% were obese, 21% had high blood pressure, 19% smokers, 8% diabetic, which is kind of low, I would think. And 36% of them had a case manager involved, 29% had an additional work comp claim, 14% had an attorney, and again, 6% had English as a second language. So patients who were obese averaged an additional almost 0.4 visits more, and that's about $100 in additional physical therapy costs. So we can take that back to the employer and say, all the people you sent to us, they might say, why is it taking 11 visits to get this patient better? And you say, well, their BMI is 44. Maybe you need to do some education on healthy eating habits and healthy weights for your population, and maybe that will help drill down some of your costs. Diabetes increases at almost 2 visits in an average claim, which is about $475 in therapy costs. So what he does, what Brian, who pulled this together, does with this is, goes out to companies and say, you know, hey, if you work on diabetes education, if you work on obesity education, you can decrease the overall cost of your claims. High blood pressure, even more. So what if they're overweight, have high blood pressure and high cholesterol? We don't ever ask high cholesterol, but I usually do, because it's like, you know, those are big risk factors. Attorneys, actually, to visit, I should have asked you to say yes, but, and that is the end of that slideshow. So